Let us discuss about the femur intramedullary nailing. As an overview, the femur or thigh bone is the largest bone of the body. The femoral shaft or diaphysis is the long straight middle section of the femur. Femoral shaft fractures are usually the result of high energy trauma such as road traffic accidents. Femoral shaft fractures may be closed, where the overlying tissues are intact, or open, where the bone is exposed, placing the person at great risk of wound infection and contamination. Intramedullary nailing is surgery to repair a broken bone and keep it stable. The most common bones fixed by this procedure are the thigh, shin bone or the tibia, the hip bone or the proximal femur, and upper arm or the humerus. A permanent nail or rod is placed into the center of the bone. It will help you be able to put weight on the bone. It provides durable, strong, and flexible support, allows more exact alignment of the fractured bones for faster healing, and may lead to earlier weight bearing, may lead to earlier joint motion for reduced stiffness. The two types of insertion portal approach for femoral intramedullary nailing is the antegrade and retrograde. For the antegrade femoral nail system is intended for use in intramedullary fixation of fractures of the femur to include the following: open and closed femoral fractures, pseudoarthritis and correction osteotomy, pathologic fractures, impending pathologic fractures and tumor resections, bone lengthening, fractures proximal to a total knee arthroplasty or prosthesis, non-unions and malunions, fracture resulting from osteoporosis, fracture in the proximal femur. For the retrograde femoral nailing is intended for use in intramedullary fixation of fractures of the femur to include the following: supracondylar fractures, including those with severe comminution and intra-articular extension, open and closed distal femoral fractures, pseudoarthrosis in correction of osteotomy, pathologic fractures or impending pathologic fractures and tumor resection, bone lengthening, fractures distal to a total hip prosthesis, non-unions and malunions, fractures resulting from osteoporosis. How should we position the patient for antegrade approach for femoral intramedullary nailing? For antegrade, the patient should be positioned in a supine position on a fracture table or radiolocent table. The use of a fracture table can be beneficial during fracture reduction by providing inline traction and facilitating intraoperative imaging with the C-arm. The C-arm should be positioned to allow for imaging of the femur in both planes along the entire length of the bone. For a retrograde approach, the patient should be positioned in a supine position on a radiolocent table with the injured leg draped free and a bumped under the ipsilateral hip. The C-arm should be positioned to allow imaging of the femur in both planes along the entire length of the bone. Place the knee of a sterile bolster to maintain approximately 30 degrees of flexion. Use manual distraction or a femoral distractor to reduce severely displaced fracture and to restore length. These are the following instruments needed for femur intramedullary nailing. First is the bone major set, power tool set, intramedullary nail sets from the company, intramedullary reamer sets, femoral distractors, olive tip guide wire, and entry guide wire 3.2 mm. Surgical technique antegrade approach. The entry point for the nail is located on the greater trochanter. On the APA image, the starting point should be on the tip of the greater trochanter. On the lateral image, the starting point should be near the junction of the anterior and middle third of the greater trochanter. Place the 3.2 mm pin guide and soft tissue protector through the incision. Align the soft tissue protector in line with the femoral shaft on the AP and lateral image views. Place the 13.5 mm cannulated entry reamer over the guide pin and ream the proximal fragments of the femur through the soft tissue protector. Use the guide wire gripper to advance the 3 mm ball nose guide wire to the level of the fracture. Alternatively, a curve reduction tool can be used to assist in fracture reduction. The 3 mm ball nose guide wire can be inserted through the curve reduction tool and into the distal fragment. The proper nail length is determined by sliding the guide wire depth gauge over the ball nose guide wire to the greater trochanter and reading the appropriate length from the calibrated line on the guide wire. And after obtaining the proper nail length, begin reaming with the 8 mm end cutting reamer. Sequentially ream until cortical chatter is achieved. Ream 1 mm to 1.5 mm over the desired nail diameter. Then attach the Antegrade radiolucent targeting guide to the appropriately sized nail using the T-handle and ball hex driver. Dependent on surgical site, a left nail is indicated by a blue proximal stripe, while a right nail is indicated by a rose proximal stripe. Introduce the nail into the proximal femur using the Antegrade radiolucent targeting guide. The jig will start anterior and will be rotated laterally as the nail advances down the intramedullary canal. If the nail does not enter the femur easily, use a mallet to apply a gentle blow to the impactor pad. It is very important to never hit directly on the radiolucent targeting guide. Remove the ball nose guide wire and place the screw sheath, 4 mm drill guide, and 4 mm obturator through the appropriate transverse hole in the targeting guide and mark the skin. Make a small incision and place the sheath, drill guide, and obturator through the incision into the lateral cortex. Then remove the obturator and drill the bone using the 4 mm calibrated drill. Measure the screw length from the end of the drill guide using the calibration of the drill. Assemble the 5 mm cortical screw onto the captured hex driver system. The captured hex driver system is assembled by placing the screw onto the 5 mm hex driver, then engaging the capturing rod. The capture construct is then connected to the T-handle. This attachment can also be used in a Hudson power adapter should power insertion be desired. Remove the drill and drill guide and place the screw directly through the sheath using the captured hex driver system. Insert the screw until the black laser edge line is at the level of the screw sheath. Verify screw positioning using fluoroscopy. For proximal targeting, reconstruction interlocking, insert the screw sheath, the drill guide, and the obturator through the targeting module and mark the incision location of the skin. Make a small incision and insert the sheath, drill, and obturator until it contacts the cortex of the femur. Use a 3.2 mm guide pin or a solid or cannulated 5.5 mm drill bit for proximal femoral screw targeting. Then place the guide pin depth gauge under the 3.2 mm guide pin and against the pin guide. Read the required length from the depth gauge, assuring that the sheath is touching the bone. Insert the 5 mm calibrated cannulated drill, blue-purple, over the guide pin. Then drill the femoral head to the appropriate depth, measuring the screw length of the calibrated lines. Remove the 3.2 mm guide pin out of the screw sheath and advance the selected screw onto the femoral head using the T-handle and 5 mm capturing hex driver. Insert the screw until the black laser edge line is at the level of the screw sheath. Using a perfect circle technique, drill bicortically in the distal femur with a 4 mm drill bit. Fluoroscopy can be used to assist. Screw length can be measured from the green line on the 4 mm drill bit reference of the distal depth gauge sled. Alternatively, a standard depth gauge can be used.